Okay guys, so I decided I wanted to do a little, just a 10-minute, hopefully 10-minute cancer review, just because after going through Jeopardy and everything, I know some people felt like it was not quite enough. I know we kind of rushed because we were trying to get to the HESI stuff. So if you wanted a little bit more of a deep dive, hopefully this 10-minute review will kind of give you what you feel like you need. Okay, so we're going to start off talking about leukemia. Now, this time I'm actually going to tell you a little bit more about leukemia than I did last time. Part of the reason why I didn't want to get into this is because we had decided we were going to focus on leukemia and pediatrics, but maybe this was also contributing to some people's confusion about leukemia. So leukemia is one of the cancers of the blood. It's one of the main cancers of the blood, one of the ones that you'll hear the most about. And you might hear us constantly explaining that we're just going to talk about this one type of cancer. That's because, as you can see, there are so many different types of cancer that have to do with just specific different types of cells within our body. So if you want to think of it as each of the different cells in our body that make up our skin and our organs and our nerves and our mucous membranes and everything, all of those can develop their own type of cancer, okay? So leukemia, when we're talking about leukemia, it's the main type of a cancer of the blood, okay? And with leukemia, so ALL is the most common leukemia, and it is especially the most common in children, and it's one of our main focuses. However, there are 4 different main types of leukemia. There's acute leukemia and chronic leukemia. There are ALL, AML, CLL, and CML. ALL is the most common one in peds, and it's typically what you see, okay? The difference, and I'm going to put on the pointer, I'm going to make it actually work this time. The difference between our ALL and our AML, if you want to look at that, or chronic, or I'll explain that in a second, is the different types of white blood cells. So it's all white blood cells. It's all about the white blood cells, but it has to do with whether it's white blood cells from lymphocytes or whether it's white blood cells from the myeloblast. Okay, so you can kind of see right here, you have the lymphoblast from the lymphoid stem cell, and then the myeloid stem cell that makes the myeloblast, right? And they're both white blood cells. They're just different types of white blood cells. Remember, we can differentiate all of the different types of white blood cells. So these are our lymphoblasts, okay? So when we are talking about ALL versus AML, it's just the specific type of white blood cells that you see those differences in, okay? Then there's chronic versus acute. So again, we're going to focus on acute. It is the one that you most typically see kill someone, to be quite honest. When you're dealing with somebody that has chronic, it's similar. Similar in that you have an excessive proliferation of white blood cells, again. However, the body is able to deal with them a little bit more, if you want to think of it that way. They are not this massive proliferation that takes over everything. It's lifelong, as far as I've been able to tell. We had a person recently diagnosed with chronic, and that was what they were telling the person, that it was going to be a lifelong battle, but generally was considered manageable. They were just going to have to be on different types of immunosuppressants for the rest of their life. So that's why we focus on acute, because it's the one that's the most serious, and it's really affects our kids. So okay. So now that you kind of know a little bit about leukemia and why we're going to focus on acute, let's talk about what you see in acute leukemia, okay? So you see this excessive proliferation of white blood cells. We talked about that in class. You heard me refer to them as baby white blood cells. They're immature blood cells. Other terms that we'll use for these are blasts, white blood cell blasts, and bands. So here's the thing. Those two words, you've heard of osteoblast, you've heard of lymphoblast now, right? Both of those words just mean immature cells, brand new immature cells. Bands is another term that we use for immature cells. Okay, especially bands is more specific to, we'll use it for blood cells, we'll use it for protein. So you want to get familiar with those terms. Those are just for medical terminology, okay? Not special to leukemia specifically. Okay, so what do you see with leukemia? Well, honestly, you just have to think about what's going on. So look at our pictures here. We have, this is our normal blood smear, if you will, right? And this is our abnormal blood smear. So our abnormal blood smear is taken over by these little leukemia cells. And here's the thing about this. These immature white blood cells are ineffective at fighting infection, right? They have taken over our blood. So now we have anemia, neutropenia, and thrombocytopenia, right? So kind of gives you your idea of what to look for your signs and symptoms of leukemia, right? So if you had somebody coming in and they were showing signs of anemia, say they were tachycardic and they were fatigued, they were short of breath a lot easier than they used to be. Neutropenia, they come in with infection. They've had frequent infections. They've had fever. They're saying that they have bone pain. I threw that into the infection section. Enlarged lymph nodes, night sweats. And then the thrombocytopenia, what would you see there? Bleeding, bruising, right? So you don't really have to think too much out of the box about what signs and symptoms you'd see for leukemia. Just think about what's going on with it. Your white blood cells have taken over everything, and they are ineffective, horrible little white blood cells that are terrible at fighting infection. So now you have somebody who's showing signs of anemia, infection, neutropenia, and thrombocytopenia. They have bleeding as well. So our plan of care is going to be focused on that. Preventing infection, preventing bleeding, bleeding precautions. Depending on what's going on, we might consider epoetin alpha if we're trying to increase their red blood cells, right? So that's the kind of stuff that we are going to look at for their plan of care, okay? Maximizing everything to prevent them from having an infection, to prevent them from falling, to manage their anemia as well, okay? So that's going to be kind of part of our plan of care. Let's move on. We're talking about tumors. Now we're going to start talking about tumors. So if you want to think, okay, I'm putting away everything I know about the diseases of the blood, now I'm moving on to tumors, okay? I think that's the way I'll teach it from now on. So our tumors that we briefly discussed brain tumor, and you'll see why I didn't get into it much detail, and then neuroblastoma and nephroblastoma. So here's the thing about tumors. So what are tumors? Tumors are where you have this massive proliferation of cells that come from the originating organ. What does that mean? Well, it means you have a cell, right? And then the cell divides and 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 divides, right? And it gets bigger and bigger and bigger and bigger. So these cells are growing at a massive rate. And I say just cells at this point in time, because you can have benign cells and you can have cancerous cells, right? So if you were to see, like, okay, well, you have a tumor, you have abnormal proliferation of cells. And now we're going to look at those cells and we're going to see, what are those cells, right? Is this benign? Is this cancerous? So when we are trying to figure out whether it is a cancerous cell, one of the things that we look at is, and you can see how I put that it looks different, and then we'll go over here. We have our laser pointer, and we talk about the tumor grade, and it looks at how differentiated the cell is. So what that means is we know what the originating cell, we can tell what the originating cell was, whether it was a squamous cell, whether it was a cell from our kidneys, a cell from our breast tissue. I mean, any of those types of cells, we can tell what the originating cell was. Now, what we're trying to find out is how different does that cell, if you want to think of differentiated, as how different does that cell look from the originating cell, right? And so that is how we can tell just how bad the cancer is what's really trying to tell us, right? So we look and we're like, it's pretty well differentiated. Ooh, it's a little bit differentiated. Oh, it's poorly differentiated, and it's undifferentiated. And this gives us an idea of how far along towards cancerous cells we are, right? And so when you look at tumors, when you see the report from tumors, this is one of the pieces that you're going to see. So if it's well differentiated, it looks basically like the original cell, it's not a tumor. But if it starts to differentiate, that's when it is a tumor, sorry, it's not cancer. When it starts to differentiate more and more, it looks different, more and more different. These are the cells that we consider cancer, right? These are the cells that we consider, this is abnormal proliferation of cells that were not the original cells. That's bad, okay? They grow at this ridiculously fast rate, and that's what I was trying to tell you guys about when we were talking about how exhausted somebody with cancer is because they're burning through their energy stores. That's where they get that cachectic look, where they just look almost anorexic, like so fatigued, so just drawn out, because their body is working so hard trying to make these horrible cells that we don't want them to make, okay? So that's kind of the first piece about what tumors are. So when we talk about a tumor on the brain, we're talking about cells from the brain that started to grow, divide, right? And they stopped being differentiated from what they looked like before. They looked very abnormal. Original cell, yes, but very abnormal. And I know that's a little hard to understand, but think about, it's a little bit easier if you think about skin cancer. So skin cancer, you can see what somebody's skin should look like. You can see what somebody's skin cells should look like. Well, when we get skin cancer, and you guys have done the ABCDE, so you know, a really abnormal looking mole, like really abnormal, like it doesn't have it has an asymmetrical border, it's got different colors in it, maybe it has pitting, maybe it even has like something, you know, secretions from it that it shouldn't have. That's what it means. So we can tell that it was the original cell when we're looking at it under the microscope, but obviously it's not the original cell anymore. It's changed. It's mutated, right? You can see it with skin cells. It's harder to imagine it when it's in your brain or your nerve system or your kidneys, which is the three that we're talking about, okay? So that's what we're talking about when we say differentiated. So the stages of tumor cancers. The stages of tumor cancers have to do with where it's grown. So you can kind of see on this little chart, if you have it in the early stage, it is an invasive tumor. It's been found, but it hasn't spread at all. It's very much localized. It's very early in its stages. It hasn't grown that big yet. We have good chances with this. The second stage is where it's localized. So it's still basically in that same area, but it's maybe spread to the cell next door. Maybe just spread out a little bit, okay? Spread to maybe the lymph nodes right over where it was. The third spread is where we have gone now further away, okay? So it's more than just the surrounding tissue. It's more than just maybe the organ next door. It's more than that. It's actually spread to maybe a distant lymph node away from where the originating mass was. And then a stage 4 is where we have different spread or distant spread. So this is what we call metastatic cancer. And this is where somebody's has spread far away from where it originated. So that's where the breast cancer spread now to the spinal cord, right? Breast and spine, they're not next door to each other. So that's where it has spread much further away, right? And so when we talk about cancers of that are tumors, we talk about their grade and their stage specifically, okay? So let's go over what we need to know for our tumor cancers. So the three main ones that we talked about, we talked briefly about brain cancer. So why did I only talk briefly about it? Well, one, there's many different types, and it is a deep rabbit hole. But the key things that you need to know, you already know. Signs and symptoms are increased ICP. So signs and symptoms or increased ICP are key, right? Increased ICP is key. Nausea, vomiting, and headache in the morning can be very classic signs. Why? They were supine all night. When they're supine and they're starting to get really nauseous and a bad headache, that's never a good thing. It's never a good thing for anyone, really. The next one, neuroblastoma. So neuroblastoma, it's the silent one. It's the one that oftentimes we don't catch until it's metastasized to another organ, until it's distant away from its original nerve. So neuroblastoma grows on the nerves. That's why you can find it anywhere throughout the body. That's why its effects are very hard to describe. Weird signs that you can see from neuroblastoma are periorbital swelling and bruising can be signs. I'm not actually telling you about this one because I think it's going to help you do an early diagnosis for a patient. I'm not. I'm telling you about this one because I think if you were to go in to take care of a kiddo with those signs and symptoms, that could be kind of shocking if you didn't know that that existed with neuroblastoma. That's why I want to tell you about it. Okay? Nephroblastoma, Wilms tumor. This is the key one to know. This is something that NCLEX likes. Okay? So this is a tumor of the kidneys. Nephro means kidneys. Nephroblastoma, blast, right, means we have a new proliferation of kidney cells, and an oma is typically referring to a tumor. So anytime you hear a blastoma, think tumor. Think tumor, okay? So it's a tumor of the kidneys. We do not palpate the abdomen. Yes, I know that the kidneys are not right in the abdomen, but that is the key thing that we want to remember because typically we don't go around palpating the flanks. I know where the kidneys are. We don't go around palpating the flanks though. We typically palpate the abdomen. Now the risk is that we can actually break open that encapsulation of the tumor that's right in the kidneys and spread it throughout the whole abdomen. That would be terrible. That would be bad. Please don't do it. Okay, don't palpate the abdomen. Put a sign up that says do not palpate the abdomen. This patient needs surgery within 24 to 48 hours of discovery. Okay? Okay, and the last slide is our medications that you want to know, and this was a little longer than I planned. So our last slide of the medications you want to know, doxorubicin and cisplatin. So I didn't pick these because they're specific to the cancers that we learned. I picked these only because, one, you guys told me that you didn't do a whole lot of cancer meds last term. Two, other than general stuff, and I know you learned the general stuff, and that's awesome. And we learned methotrexate and A7, so that was perfect. But these meds, when I looked into it, they said that they were some of the most commonly tested ones on the NCLEX. I saw it in more than one resource. So we're going to know them, and this is a good time to learn them, so you're not trying to learn them right before you take the test or your exit exam or any of that stuff. So doxorubicin is your very classic chemo med because it kills everything, causes all the bad, right? The hair loss, the weak skin, hyperglycemia, tissue necrosis, bone marrow suppression, all the classic things that you should worry about. Also causes cardiotoxicity. I did find several questions related to cardiotoxicity in like review books. So that's a good one to know because it stands out. And I think that's probably one of the reasons why NCLEX likes it. So I didn't tell it to you guys originally, I think in my morning class, but it also causes cardiotoxicity, okay? So if you have a patient that has also that leukopenia, so less than 4,000 white blood cells, it's never a good thing. They're a bleeding risk, and any temp over 100.3 is priority. Don't make fun of me. Okay, And then our cisplatin, think cisplatin. Why? Because it's never toxic. So you want to think of all the things that mean never toxic. So creatinine greater than 1.3 equals bad kidney. BUN over 20. Don't have a phrase for that one. And 30 mLs or less equals kidney distress. Okay, this is always good to know, and especially just go ahead and relate it to the med and you'll be fine, right? Hydration is really, really important over the next 3 days. And an antiemetic is important for almost all chemomeds. We want to give them an antiemetic before we give them the chemomed. If we're giving chemomeds through an IV line, we want to check for blood return from that IV line before we'd ever give them chemomeds. Why? Because absolutely we never want it to infiltrate into their skin because it is going to destroy their skin. Tissue necrosis means it could destroy their skin. So that is terrible, horrible. It's also why we're really cautious when we give chemomeds. We always would have 2 gloves on at a minimum. The idea of spilling it anywhere, it's toxic, it's terrible, don't do it. So always check for blood return. Always continue to check your site if you have chemomeds going. Every hospital should have a policy, but if you want to think of your most cautious policy, I think that would be the best. You know, your Q15, Q30, Q1 hour, never ever pick the longer time away. But like I said, every hospital has its policy, and then it depends on your patient population as well. And then if you're doing cisplatin, do a saline rinse after. And that's all I got. Thank you.